Good day, doc, and everyone. Today we're going to explain about cross anatomy of liver. We are group 3. The numbers are Jeeva Bharati, Kavipriya, Kritika, Laksha, Madhava, Maulishwaran, Mohanapriya, Nimteshoya, Pooja. Our topics are liver, location and description, important relation anteriorly and posteriorly, peritoneal ligaments, hepatic blood circulation, blood supply, lymph drainage, nerve supply, and clinical notes. Introduction. It is the largest gland of body, occupying much of this right upper part of abdominal cavity. It consists of both endocrinic and exocrinic part. The liver perform a wide range of metabolic activity necessary for homeostatic nutrition and immune response. Liver. Liver is the largest gland in the body and has a wide varieties of functions. Three of these basic functions are production and segregation of bile, which is passed into the intestinal tract, involving in many metabolic activity related to carbohydrate, fat, and protein metabolism. Filtrations of blood, removing bacteria and other foreign particles that have gained entrance to the blood from the lumen of the intestine. The liver synthesizes heparin, an anticoagulant substance, has an important detoxifying function. It produces bile pigment from the hemoglobin of worn out red blood cell capsule and segregate bile salt. These together are converted to the duodenum by the biliary ducts.
Hi, I'm Pooja. Now I start with the location. Occupies right hypochondrium, upper epigastrium, part of left hypochondrium up to mid clavicular line. It extends up to fifth rib anteriorly, right side below right nipple, and left fifth intercostal space. Its inferior border is crosses middle line at transpyrolic plane L1 vertebra. Location and description. It is soft, pliable, and highly vascular, occupies upper abdominal cavity beneath the diaphragm, divided into right and left lobes by falciform ligament, right lobe further divided into quadrate and caudate lobes. Porta hepatis located on the posterior inferior surface, surrounded by fibrous capsule and partially covered by peritoneum, composed of liver lobules, portal canals, and sinusoids. Key feature of it is upper surface convex molded to diaphragm, posterior inferior surfaces irregular, contacts adjacent viscera, lobes are right, left, quadrate, and caudate. Porta hepatis contains hepatic duct, arteries, portal veins, and nerves. Liver lobules. It is also known as hepatic lobules. The liver may be divided into a large right lobe and a small left lobe by the attachment of the peritoneum of the falciform ligament. The right lobe is further divided into quadrate lobe and a caudate lobe by the presence of gallbladder, the fissure for the ligamentum teres, the inferior vena cava, and the fissure for the ligamentum venosum. The quadrant and caudate lobes are a functional part of the left lobe of the liver. Thus, the left and the right branches of the hepatic artery and portal vein and the right and left hepatic ducts are distributed to the right lobe and the left lobe. Quadrate plus caudate lobes respectively. Apparently, the two sides overlap every little. The porta hepatis or hilum of the liver is found on the posterior inferior surface and lies between the caudate and quadrant lobes. Important relations. Anteriorly, diaphragm, right and left costal margins, right and left pleura and lower margins of both lungs, xiphoid process, and anterior abdominal wall in the subcostal angle. Posteriorly, diaphragm, right kidney, hepatic flexure of the colon, duodenum, gallbladder, inferior vena cava, and esophagus and fundus of the stomach. Ligaments. Fast False ligaments: falciform ligament, coronary ligament, right triangular ligament, left triangular ligament, lesser omentum. And the two ligaments are ligamentum teres, ligamentum venosum. The next few topics are explained by Mona Priya.
Hi, I'm Mona Priya. I start with peritoneum ligaments. First, by a falciform ligament. It connects to the liver to the anterior abdominal wall and diaphragm without containing vessels. Coronary ligament attaches the liver to the diaphragm and defines the bare area of the liver with no vessels inside. And right triangular ligament, a fold of coronary ligament at a right edge of the liver that does not contain vessels. Left triangular ligament formed by the left edge of the coronary ligament attaching the liver to the diaphragm on the left side without vessels. Lesser omentum. The lesser omentum is a double layer of the peritoneum that connects the lesser curvature of the stomach and the first part of the duodenum, small intestine, to the liver. Next, the ligamentum teres. It passes into a fissure on the visceral surface of the liver and joins the left branch of the portal vein in the porta hepatis. Ligamentum venosum, a fibrous band that is remains of the ductus venosus, is attached to the left branch of the portal vein and ascends in a fissure on a visceral surface of the liver to attach above to the inferior vena cava. In the fetus, oxygenated blood is brought to the liver in the umbilical vein. The greater proportion of the blood bypasses the liver in the ductus venosus and joins the inferior vena cava. At birth, the umbilical vein and ductus venosus close and becomes fibrous cords. Hepatic blood circulation. The blood vessels conveying the blood to the liver are the hepatic artery and portal vein. Hepatic artery, the percentage of the hepatic artery is 30% and portal vein, which is about 70%. The hepatic artery brings oxygenated blood to the liver and portal vein brings venous blood rich in the products of digestion which have been absorbed from the GI tract. The arterial and venous blood is conducted to the central vein of each liver lobe by the liver sinusoids. The central veins drain into the right and left hepatic veins and these leaves the posterior surface of the liver and open directly into the inferior vena cava. And blood supply. The blood supply of the artery, the hepatic artery, a branch of celiac artery, divides into right and left terminal branches that enter the porta hepatis. And vein, hepatic vein and portal vein. The portal vein divides into right and left branches that enters the porta hepatis behind the arteries. Lymph drainage. The liver produces a large amount of lymph, about one-third to one-half of all body lymph. The lymph vessels leave the liver and enter the several lymph nodes in the porta hepatis. The efferent vessels pass to the celiac nodes. A few vessels pass from a bare area of the liver through a diaphragm to a posterior mediastinal lymph nodes. Nerve supply. Celiac plexus. Sympathetic and parasympathetic nerves form the celiac plexus. The anterior vagal trunk gives rise to a large hepatic branch which passes directly to the liver. The next few topics will explain by our teammate Gio Bharati.
Hello everyone, this is Jiva Bharati. Clinical notes: liver supports and surgery. The liver the liver is held in position in the upper part of abdominal cavity by the attachment of hepatic veins to the inferior vena cava. The peritoneal ligaments and the tone of the abdominal muscles play a minor role in its support. This fact is important surgically because even if the peritoneal ligaments are cut, the liver can be only slightly rotated. Liver biopsy. Liver biopsy is a common diagnostic procedure with the patient holding his or her breath in full expiration to reduce the size of diaphragmatic recess and the likelihood of damage to the lung. A needle is inserted through the right 8th or 9th intercostal space in the mid-axillary line. The needle passes through the diaphragm into the liver and a small specimen of liver tissue is removed from the microscopic examination. Subphrenic stresses: an abnormal accumulation of gas or fluid is necessary for Separation of the peritoneal surfaces. The anterior surface of the liver is normally dull on percussion. Perforation of a gastric ulcer is often accompanied by a loss of liver dullness caused by the accumulation of gas over the anterior surface of the liver and in the subpharynx spaces. Now let's see the disease of some diseases of liver. First we have the congenital and the genetic disorder. The description to the disorder lies in it's a disease of liver that are present from birth or arise due to inherited genetic mutations. Anatomical basis Wilson's disease, which is due to excess copper accumulation in the liver due to a genetic defect in copper metabolism. Hemochromatosis, excess iron accumulation leading to liver damage and cirrhosis. Alpha-1 antitrypsin deficiency, a genetic disorder that causes abnormal protein buildup in the liver, leading to liver damage. Portal hypertension, the anatomical basis is the portal vein, a major vessel draining the intestines to the liver, plays a critical role in the liver function. Diseases like cirrhosis can increase resistance to blood flow through the liver. Its effects increase pressure in portal veins causes complications such as Behçet's enlarged veins and ascites, fluid accumulation. Hepatitis, inflammation of the liver. Hepatocytes, the functional cells of the liver, are arranged in plates with sinusoids in between. Hepatitis results in inflammation and damage to these hepatocytes. Diffuse inflammation can lead to liver dysfunction, scarring, and eventually liver failure. Cholestasis, the liver produces bile which is transported via the bile ducts. Cholestasis is the interruption of bile flow either due to intrahepatic, that is within the liver, or extrahepatic, outside the liver blockages. Impaired bile flow can lead to jaundice and liver damage. The reference to this PPT is taken from Snell's book. Thank you for listening to the PPT. Thank you for listening to the presentation.